Cushing syndrome is caused by chronic elevated levels of glucocorticoids in the blood. Glucocorticoids are steroidal hormones that have pleiotropic effects that play a role in the immune system and metabolism. If you break down the word glucocorticoid, its constituent parts refer to the roles of these hormones in glucose metabolism, their site of synthesis within the adrenal cortex of the adrenal glands, and, of course, their steroidal structures. Since steroids are hydrophobic, when glucocorticoids leave the adrenal glands, they are transported in the blood by protein carriers, chiefly the glycoprotein transcortin. They are then able to spontaneously cross the membranes of their target cells. Within cells, glucocorticoids act by interacting with cytosolic glucocorticoid receptors. These receptor-ligand complexes are then translocated into the cell nucleus, where they function as transcription factors to activate, and to a lesser extent repress, gene activation. The main glucocorticoid normally produced by the human adrenal cortex is cortisol. In fact, Cushing syndrome is also referred to as hypercortisolism. Cortisol is an essential hormone whose main function is to restore homeostasis following exposure to stress. As such, the effects of cortisol are felt virtually all over the body, and its primary targets are metabolic. Cortisol also affects ion transport, the immune response, and cognitive functions, however. In sugar metabolism, cortisol counteracts insulin and contributes to hyperglycemia. This hormone increases hepatic gluconeogenesis and increases insulin resistance. Cortisol also supplies precursors to gluconeogenesis by increasing amino acid concentrations in the blood. To do this, it inhibits protein synthesis, decreasing amino acid uptake in the muscle, and inhibits formation of collagen. As collagen is a main organic component of bones, tendons, and other connective tissues, cortisol decreases formation of these tissues. Cortisol also has repressive effects on the immune response. For example, cortisol plays a role in disrupting T-cell proliferation and cell-mediated immunity. Cortisol also downregulates inflammation. Given the roles that glucocorticoids, especially cortisol, plays in the body, the presentation of Cushing syndrome makes sense. Patients suffering from the syndrome have high levels of insulin and may complain of increased weight gain, especially in the face, where the rounding of the face is often described as moon face, the supraclavicular region, which is often unflatteringly described as buffalo hump, and the torso. Unsurprisingly, these individuals also have increased risk for hypertension and diabetes mellitus. In addition, because of the muscle-wasting properties of chronic elevated cortisol, patients may also have progressive muscle weakness and exhibit thinner than expected extremities. Further, the cortisol-dependent downregulation of collagen production often leads to pronounced abdominal striae, thinning of skin, ease of bruising, and the decreased ability to heal wounds. Similarly, chronic cortisol-dependent downregulation of bone formation give an afflicted individual elevated risk for osteopenia and even osteoporosis. To make matters worse, because the cortisol suppresses immune function, sufferers of Cushing syndrome are more vulnerable to infection. Finally, although we haven't discussed the mechanism, patients with Cushing syndrome may develop psychological problems such as depression or cognitive dysfunction. So what's the cause of Cushing syndrome? Glucocorticoids can become elevated in the blood through both endogenous and exogenous sources. Exogenous Cushing syndrome occurs when a person takes glucocorticoids as part of a treatment for a disease. An example of this is taking prednisone, a synthetic glucocorticoid, for the purposes of treating inflammatory diseases such as asthma or arthritis. There are a few common endogenous causes of elevated glucocorticoids. One cause is primary adrenal hyperplasia, or unchecked growth of the adrenal glands. Such a development may induce a single adrenal gland to produce more cortisol directly. The unaffected adrenal gland may atrophy in such a scenario. Adrenal adenomas, or benign tumors, or carcinomas, or malignant tumors, may also increase the output of glucocorticoids from the affected gland. The adrenal cortex may also be induced to produce more glucocorticoids by lesions distal from the glands. In fact, a common endogenous cause of elevated glucocorticoids is an increased production of adrenocorticotropic hormone, ACTH, which is produced and secreted by the anterior pituitary gland. Its principal effect is to induce the adrenal gland to produce more cortisol. ACTH is often increased as a result of an ACTH-secreting pituitary adenoma. Adrenal hyperplasia may also be induced by paraneoplastic ACTH secretion. For example, small cell carcinomas of the lung can secrete ACTH ectopically, which induce the adrenal glands to produce more glucocorticoids. Doctors may suspect Cushing syndrome based on their observations during physical examination. To verify that suspicion, diagnosis of endogenous hypercortisolism requires the demonstration of elevated serum, salivary, or urinary cortisol. Often, a 24-hour urine test is administered to test for cortisol concentrations. Diagnosis may also be confirmed via a low-dose dexamethasone suppression test. Dexamethasone is a cortisol analog that suppresses ACTH production in the pituitary gland. Of course, this method requires that the cause of the hypercortisolism is excess ACTH from the pituitary gland. Treatment of Cushing syndrome depends on the cause. If an exogenous therapeutical glucocorticoid is suspected to be the cause of Cushing syndrome, the treatment may simply be to try another therapy. If an endogenous source of hypercortisolism is suspected, the treatment may take the form of a high dose of dexamethasone to suppress ACTH production by the pituitary adenoma. This treatment would not work, however, if the hormone is produced ectopically by an ACTH-producing tumor that is insensitive to dexamethasone. This is why optimal treatment of Cushing syndrome often involves removal of causal tumors or even performing an adrenal adectomy to remove the affected adrenal gland that is overproducing cortisol.